Good morning, welcome everyone. I would like to present my PhD topic, which is antimicrobial therapeutic drug monitoring in critically ill patients by a clinical pharmacist. I am a pharmacist working for 6 years at the University Pharmacy Department here at Semmelweis University, and during my residency I became interested in critically ill intensive care clinical pharmacy. My vision is to create a strong cooperation between the intensive physicians, the clinical pharmacist, and the clinical laboratory concerning of antibiotic therapy, and to promote this antimicrobial therapy through therapeutic drug monitoring. I have two ongoing projects, and the specific goals are to investigate the effect of beta-lactam TDM in critically ill patients, and the second is to evaluate the pharmacokinetic-based guidance of colistin therapy. So my first project is guiding the administration of beta-lactam antibiotics by therapeutic drug monitoring improves the probability of attaining clinical cure in critically ill patients. The methodology what was used is systematic review and meta-analysis. Regarding the background, around 70% of the critically ill patients admitted to intensive care unit receives antibiotics, and the beta-lactams are the most frequently prescribed of them. But the pharmacokinetics of these drugs in these patient populations varies considerably, so there is an uncertainty of the effectiveness of these antimicrobial therapies, and therapeutic drug monitoring, which means the measurement of the drug concentrations in the blood in specific intervals, is an essential tool to provide evidence through individualized therapy. And so we would like to evaluate the impact of antimicrobial TDM in critically ill patients. We phrased the clinical question as is TDM guided beta-lactam antimicrobial therapy more effective than standard of care therapy. So the population were the critically ill adult patients receiving beta-lactams, and we compared the TDM guided adjustment of beta-lactam therapy to the standard of care therapy when we administer the antibiotics as one size fits all, so as the on-label therapy. We had 4 outcomes. The primary was clinical cure. We conducted a systematic literature search, I can never say this word, in 3 main databases, and we yielded almost 3,000 records, and 7 were found to be eligible for our data extraction. The primary outcome was clinical cure, and you can see on the forest plot that TDM, the odds for clinical cure in TDM group is more than 2 times higher than in the standard of care group. This is the both clinically and statistically relevant and significant result. The second outcome was microbiological eradication. Here we conducted both the common effect model and the random effect, and then we kept the random effect model. There is a tendency, that is almost 2 times higher in the TDM group, the microbiological eradication, but we cannot declare it as a statistical significant result, but it is a tendency, and it is marginally non-significant. We had 3 more outcomes, both hospital mortality and IC mortality. Here we neither can declare any because diamonds does not favor either side, so we cannot declare a final statement. But if we think about that mortality is a hard endpoint and is influenced by several other things during therapy, we can say that it needs further research. Regarding length of ICU stay, if you look at the forest plot, we can declare that in the TDM group, the patients are half day less on the ICU than standard of care, so it's also not really a clinical relevant result. As for conclusion, I can say that using TDM is beneficial for increasing clinical and microbiological cure, and we found out, if we have to say something very adequate to our research, that homogeneous patient population and subgroups of antibiotics are needed, because critically ill patients are a very heterogeneous population regarding diagnosis, condition of patients. Standardization of protocols and clinical endpoints are also essential. The implications for clinical implications, I can say that TDM-guided administration of beta-lactams should be facilitated in intensive care, but of course RCTs are needed with greater sample size and standardization, as I said, of clinical protocols for PK/PD index calculations. And it was not the scope of our study, but cost effectiveness would be also very useful in the future. And the strength of our study is that this is a first meta-analysis with beta-lactams. We had the quantitative outcomes, and the endpoints bear direct relevance to clinical decision making. The limitations was that small sample size. We had around 800 patients included, and we used also observational studies, not only RCTs. And as I mentioned, the heterogeneous population and risk of bias were also limitations. This is the current status of my manuscript. It's still under edition, but we would like to submit it in critical care medicine, with one of the most distinguished journals in the field, and during the pre-submission inquiry, they replied very promising about submission. Our focus was on this second project in the recent 2 months, which is clinical evaluation of the pharmacokinetics-based guidance of colistin therapy. This is the protocol writing, and also it's in clinical phase. The background of this topic is that therapeutic use of colistin was discovered back in the 40s, but it was abandoned because of its narrow therapeutic use and index and nephrotoxicity. But during the last decades, due to the emergence of the gram-negative superbugs like Pseudomonas aeruginosa, it is also daily used in the clinical therapy, but we don't know about its effect and outcome on therapy, and here therapeutic drug monitoring was also useful. And also I would like to emphasize that no methodology has been available for the TDM of colistin. It is a very complex drug, and polymyxin, it belongs to the group of polymyxins. A and B are together, and it's an inactive product which transfers in the blood into colistin. We use colistin methanesulfonate as a drug. It has a wide distribution, it has 50% protein binding, and it eliminates with glomerular filtration. We can phrase the clinical question: how should colistin be dosed and monitored to improve its therapeutic efficiency in critical care? So the methodology is the same. How should it be administered individually compared to standard of care therapy? I would like to show you, I think, one of the most important slide that shows the therapeutic drug monitoring circle, and here you can see that we are collecting blood samples from the patients. Then the laboratory medicine specialist with some technique of chromatography do the sample calculation, and then the clinical pharmacist is interpreting the results, and then with the physician, the intensive care clinician, we adjust the dose of a drug, and then the personalized therapy is given to the patient. So I think the multidisciplinarity of this work is the key point here. Regarding the status of my second project, we obtaining the ethical approval, the development of the analytical method has been done, so as the stability of studies, the technical validation, and we are in the phase of clinical validation. And now we are doing the data analysis, and because this work has been chosen for oral presentation at the upcoming TDM Congress in Prague, we are working on 3 cases which will be presented in this whole framework in September. So I have 2 ongoing projects, and through these projects I would like to achieve my goals. And I would like to finish my speech with Marie Curie's quote. Time by time I was thinking to change this quote, but I think it's more adequate now than before. So, and I would like to thank you for your cooperation and work during the last year. Thank you very much.
Thank you. I have 3 questions actually. One is that in your conclusion, first project, in addition to the first statement, which is correct, you also mention on homogeneous groups and standardizing protocols. However, your research wasn't focusing on that. All I'm saying is that it may not be worth leave those statements in the conclusions, but you could put them in the application for research and clinical. If you see what I mean.
Yes, absolutely. I just wanted to make something not a general conclusion, something more precise.
But just, anyway, just to bear in mind this. So my second one goes for what? Anyway, the third one then. The third question: why did you choose critical care medicine and not critical care or intensive care medicine? Well, I'll tell you why. Yes. Because I just mentioned to Peter that critical care medicine is the only journal which was unable to increase its impact factor during the COVID-19, whilst critical care jumped from 10 to 20, intensive care medicine jumped from 20 to 40. Okay. So, and that leads to my second question, back to us. So, because your main finding is the cure and the clearance of the bacteria. And your results are not significant on the other outcomes. So how will you reply do you have a strategy? What will you say to the reviewers if they criticize that, okay, you have shown that there is some benefit on your primary outcomes, but all the important secondary outcomes are not supporting the pathophysiological advantage of TDM. So what will you reply to the reviewers if they ask you this clinical significance of your findings?
Yes, thank you very much for your comments. First of all, we will think about then maybe we should change the target journal.
Yeah.
I think the clinical cure and the microbiological cure are key points to the critically ill patient's outcome. But yes, we should develop a strategy how to answer on these. Thank you for this comment. I still have to think about it.
Why did you pick critical care journal and not microbiological?
We sent this pre-submission inquiry to antibiotics, but they said they are not. They might not be interested on this. Yeah, so, but we will think about these journals.
I can have one which may be related to the previous questions that in your, I mean, time is running out, but I think this is important that we understand. That in your secondary outcomes in the first study, I mean, the deviation was very wide in some of the studies. So that may relate actually to that you don't get any kind of clear outcome of this. So what is the reason that some of the studies have narrow deviation and some others are very wide? This is the exclusion criteria or what in your first study?
As I said, we had both RCTs and both observational studies, which were retrospective. So maybe that was an issue for this wide. Here we are. I think you were thinking about this.
But you see that if this is this wide, I mean, maybe the evidence is not very strong. That maybe, I mean, I don't know, but you should look deep into these studies. That what could be the reason for this? Because I think that's important to discuss.
The design of the studies, that's why.